Okay, so I'm going to slowly start the presentation. So thank you for being here for the Nursing Spotlight of the month. For those who don't know me, my name is Rafaela. I'm one of the advanced practice nurses in surgery at the Montreal General Hospital. Today we have about 30 minutes together. I will let Marie-Ève Leblanc take the lead just to announce a few things about general topics about the Spotlight. I then have a Kahoot to share. I also have afterwards audit results I would like to share, some available tools and resources, and then finally the recommendations. So I will pass it on right away to Marie-Ève.
Merci, Raphaël. En fait, je vais juste prendre 2 petites minutes pour répondre. C'est-à-dire qu'il y a plusieurs équipes qui sont venues vers nous, l'équipe des pratiques professionnelles, les conseillères cadres, pour un peu savoir de quelle façon on allait soutenir les équipes avec tout l'exercice de priorité. Donc, juste pour vous tenir au courant, on est 6 conseillères cadres. On s'est divisé, rencontrer les équipes, c'est-à-dire qu'on a identifié 22 équipes, je crois, qui ont identifié une des priorités qui était dans les spotlights des 3 premiers mois au calendrier. Donc, on rencontre les équipes de leadership pour, d'une part, savoir où ils en sont avec leurs réflexions ou leurs travaux et savoir s'ils ont besoin de soutien et si oui, un soutien là, de quelle nature. Fait qu'on a commencé à rencontrer quelques équipes. On va finir de rencontrer ces 22 équipes-là pendant le mois de février et on rencontrera les autres équipes qui ont choisi des priorités qui se situent plus loin dans le calendrier une fois qu'on aura rencontré là, ces 20 premières équipes-là. Donc, en gros, on rappelle que ce qui est souhaité, c'est vraiment une approche d'équipe à ces priorités-là. Donc, ça n'appartient ni à la manager, ni à une NPDE ou à une CNS, ou une APM, mais vraiment à l'équipe d'aborder ces priorités-là. Et vraiment de commencer par circonscrire le besoin, vraiment identifier le besoin pour ensuite pouvoir planifier en identifiant les stratégies qui sont nécessaires de mettre en place. Mais on va rencontrer là, à l'issue de tout ça l'ensemble des équipes. Donc voilà, je vais juste vous tenir au courant. Si vous avez des questions, vous pouvez toujours m'envoyer un courriel. Sinon, je repasse la parole à Raphaël pour le reste du webinaire. Merci.
Merci, Marie-Ève. Okay. I'm actually going to start off the webinar with a Kahoot game, so nobody actually falls asleep after lunch today. So I'm just going to get that open right now. So you can let's start this off. You can log on directly with the PIN number here or the QR code. Okay, so I'm going to start it off. If ever there's still participants who wants to start off after, the PIN number stays at the bottom, so you can always join us afterwards. So question 1 will come. Pain can be classified according to and select all answers that apply. So we have time course, we have inferred pathophysiology, location, and etiology. Okay. So the time course was evident to pretty much everybody, and pretty much the three others as well. Okay, good. So all answers were actually correct. I have a little graph here that explains a little bit in very summarized way how we can classify pain. So yes, according to acute or chronic. We use the 3-month mark as soon as it's for chronic for the MUHC, but literature does discuss as well debate between the 3-month and the 6-month time course. We have malignant or non-malignant pain, and then we have the pathophysiology of the pain. Is it nociceptive or neuropathic? I won't go too much into detail today, but this showcases to you that how we should classify pain to be adequately able to then manage it better afterwards. Next question. So your patient has abdominal pain for 2 weeks with nausea. What type of pain do you think he has based on what we just saw? So would it be acute somatic pain, chronic visceral, acute neuropathic pain, or acute visceral pain? Oh, yes, indeed. Acute visceral because it's for times 2 weeks. From what we gather here, it is not acute somatic pain because really it touches the abdomen region. So we can put the hypothesis that it touches really a solid viscera. Next question. When should you assess your patient's pain? And this is a multi-select question. So either at admission or at visit for ambulatory sectors, before and after a procedure, which can be painful, minimally once per shift, if there is a change in the patient's medical status, and before and after giving an analgesics. It was actually everything here. So the majority got it. We actually have to assess pain very often. So yes, at admission or every visit for ambulatory sectors and minimally once per shift. And we have to target whenever there is a painful procedure before and giving analgesics because we want to see if actually it was helpful. And if ever there is a change in medical status, we want to know if there's pain to be able to guide us of what the issue is behind that change. For documentation, let's go back actually about this question. For documentation about this pain, well, it depends very much on your clinical sector. If you're in ambulatory sectors, it would be your dedicated flow sheet. So these are probably all words that you will be using. For example, emerge as well, you would be using MEDURGE. For inpatient cares, you would put your severity of your pain in OASIS, in clinical measures, and do a complete assessment, otherwise in your progress notes. This is what a complete pain assessment should include. The PQRSTU is what is recommended by the OIQ. We also added in our protocol within the MHC the option of doing a OPQRSTU-V, which is recommended by the RNO. It's very similar both, but has their own a little bit of the differences. And this really reflects the biopsychosocial model of patient's pain experience. So whenever there is a pain experience at admission, we recommend that they do a complete assessment, and this is the acronym that can help them guide in doing so. This complete pain assessment should be found in the progress notes or MEDURGE or award, but really the progress notes for inpatient care units, that's where it would be found. Next question. True or false, a behavioral pain scale is more suitable than a patient's self-report of pain. It is false. If the patient is able to self-report their pain, that's or to go to. So the patient knows what's going on the best. So we have to find that information from them first. When that's not possible, that's when we would actually turn to our behavioral pain scales, or even validate with the family members as well is another option. But the patient self-report is the number one go-to. So there's a lot of pain assessment tools out there that we combined. We combined a lot in our protocol for assessing pain. So in appendix, you'll see a list of different tools and instructions on how to use them, and clinical considerations as well. So this is just to name a few here, but depending on your population that you have on your units, choose the one that you really think is the most appropriate based on that population. And for one patient to another, we could definitely don't need to use the same one. We really need to adapt to who's in front of us. True or false? Administering Tylenol with NSAIDs with an opioid will help minimize the amount of opioids necessary. It is true. It is. This is called actually having a multimodal approach, the multimodal analgesia. So combining different medication analgesics will actually help find that comfort zone. So having that pain relieved, but without having too many side effects present. So it really proved that it works well. And we should not as well forget our non-pharmacological strategies as well, even though we just talk about meds here right now. But yes, indeed, important to ask ourselves, is other medication other than opiates on board for our patient? Next question. Usually, what is the first sign of CNS and respiratory depression caused by opiates? A desaturation, patient snoring, hypotension, a decrease in level of consciousness, and increase in level of sedation. So the majority has the correct answer. It is really the decrease in level of consciousness, the first sign that we should be seeing. The snoring would usually happen afterwards for some patients. Desaturation is actually a late sign, and hypotension does not necessarily occur in CNS or respiratory depression. We have to be really on the lookout of that our level of sedation, and that's what we need to monitor actually when it comes to opiates. I think we have one last question. And that's also why we need to actually assess the risk factors of our patient before we give an opiate. The risk factors can be found in our policy about opiates, but also on the form, the surveillance form. So there are 11 risk factors for a patient. As soon as there's 2 risk factors present or more, we say that they're particularly at risk. And that's where we should be questioning ourselves, okay, what more can I do to make sure that this doesn't happen? This is the last question. Which medication increases the risk of CNS respiratory depression? So you need to be vigilant when you administer an opioid at the same time. And this is a multi-select question. Indeed, everything actually here. It's actually surprising the number of meds that our patient that actually can cause sedation or decrease the level of sedation on our patients. And that's where clinical judgment kind of needs to come into effect and say, oh, this medication just got started. I have to be careful. My risk factors are now for my patient has now increased. So indeed, we need to be vigilant when it comes to, and this is just some examples of class of medications and example of medications, but there is a lot out there. We are working on putting a list. There is a list that from the pharmacy department, non-exhaustive list, but we are looking at making a bigger, more detailed list to help nurses as well. So this should come as well soon. But that concludes our Kahoot. And this is examples of interventions to put into place if your patient is at risk. So increasing the frequency of monitoring, moving the patient closer to the nursing station, involving the family as much as possible, and avoiding administering closely together opiates and other CNS depressant meds. Let's look at our podium. M is first place. Congratulations, M. I don't know who that is, but congratulations. I'm looking at the names at the chat. I hope you enjoyed the Kahoot. The Kahoot is available to nurses. It was shared in the bulletin that just came out, and it's also on the sway that was sent last week. It can be found multiple ways, and you can gladly share it with your team. It kind of serves as a little reminder, refresher, and hopefully makes you think about our practice. So I'm just going to go back to my presentation. Oliver, I guess your question was maybe about the Kahoot being shared. Do you want to ask your question now?
It wasn't a question, it was an error. Sorry.
Oh, okay. Good. Okay, so I will share with you all what audit were conducted so far. I'm just gonna switch. Okay. This is a reminder as well about whenever there is an opiate given, that for non-critical care areas, the expected practice is to use the specific form for opiate surveillance, which is the DM 1817. For critical care units, it would be to use their own flow sheets or Medurge, and for ambulatory, ideally prioritize this sheet if possible, otherwise in their own forms. When it comes to patient feedback, we have information on Power BI about pain, and if we look at the past results, if we look specifically for P1 to P6 for the year of 2024-2025, we see that 61% in average of patients who responded usually or always to the question, how often was their pain well controlled? So we see that it's actually similar to the years of 2023 and 2022, but still quite not very high. If you look at question number 2 on the right-hand side, the question was, how often did the hospital say did they do everything they could to help with your pain? In average, 74% of respondents replied usually or always. If you're interested to see your unit's precise results, you can do that on Power BI. This is just a summary of the results of specific units, but be mindful of the total number of respondents, because some units don't actually have a big number of respondents. So here are the results for specific units here, and we can keep track of this on Power BI. Everyone can go access to it. But it's important to go see what actually our patients are telling us. Sorry, I'm finishing up a big cold, so I need to drink a lot of water. So these are results for pain assessment at admission. So really what was looked at here was the pain intensity if it was documented either in OASIS or Centricity for D6 or for flow sheets for critical care. And also the progress notes were looked at least for the admission one. And really, the criteria was that patient's chart needed to be scanned and patient needed to be hospitalized. I targeted specific units and precisely the units who chose pain as a priority for the year of 2025. So these are the overall summary. In total, 91 audits were done. And in average, 54% of the time, the pain intensity was documented in one of those either in OASIS, Centricity, or flow sheets. If we look a bit more in detail in the progress notes where the PQRSTU should be found, for patients who did actually have pain, we see that no patient actually had a complete assessment conducted as well. So this is really a summary, and it showcases that we should actually improve our documentation around pain assessment when it comes to admission. If we look at audits conducted for opioid surveillance, I targeted units who are supposed to use the DM 1817, so non-critical care areas. And I also compared these results to the audits that were done in July of 2024. So the criteria for this one, patient's chart needed to be scanned and the patient needed to have received minimally once a PO or sub-Q dose of an opioid. So as we can see globally, 60 audits were conducted across all 4 adult sites. In average, 37% of the time, the opioid form was initiated, so for 19 patients. And if we look a bit more in detail, 51% of the time, the risk factors were completed. 84% of the time, the pre-administration assessment was completed. And unfortunately, a bit lower for the post-assessment. 19% of the time, it was completed after giving the opiate. So we can see that some units actually do quite well in initiating the form, while others are not really initiating at all the form. We're kind of assuming that the post-monitoring is not done if the form is not completed. So I would suggest here to do, once again, a review of the expected practices of actually filling out the form and the importance of completing it adequately as well. When it comes to tools and resources, we have policies and protocols on our internet. We have one specifically for opiate surveillance and monitoring, etc., and we have one for pain assessment and management. We have learning modules for certain pain modalities, which I didn't really talk about this time around for this spotlight, but I am hopeful that it will be one of the topics in the next ones. And we also have tools for teaching to patients, which not everyone knows, but there is 2 interesting tools right now in the internet that are quite generic that can be used pretty much at any site. The one on the left is bilingual, and the one on the right all exist in French and English. So they're both available on the internet. I also, with the spotlight, I created a tip sheet on when to assess pain, what should be included in our pain management strategies. A reminder as well if an opioid is administered, what to do. So this can be found in the intranet, as well as the Kahoot game that we just played together. We also have a specialized team depending on your site, so it's really important to discuss about them because they're a good, very, very good resource. We have the acute pain service, we have the chronic pain service, cancer pain and supportive care service. We have the neuromodulation clinic and the neuropalliative care service at the neuro, and at the children's as well. We have APS and complex pain service. So this is just reminders on how to reach them. Finally, just to conclude, recommendations here for managers, really, if your unit has audit results, I would invite you to share the audit results to your team and to support your team members in putting strategies or projects in place and in order to improve practice. For NPDs, NPA, and APNs to review expected practices at the MHC and share the tools and resources as well as supporting your team. And specifically for nurses and LPNs, the importance of conducting and documenting your pain assessment is really important. I invite you as well to think about adopting a multidisciplinary and multimodal approach when it comes to managing pain, and to really complete the monitoring around opioid administration. That concludes the webinar. I think we do have a few minutes to spare. If ever there's any questions right now, I would be happy to answer them. Otherwise, I'm always reachable by email. Yes, Oliver.
For the opioid surveillance sheet, would you happen to know why it's so good at the Glen and not so good at the general? Other than the general sucks. Just kidding. Like, is there a different process? Like, I'm just curious to know why they're so good.
Interesting observation.
I can't, man. 100%, 100%, 100%.
That it was initiated doesn't necessarily mean that it was 100% like 100% complete if you look on the right hand side. But yes, like I can't speak, I can speak to specifically those units to see how they introduced it, etc. But I can't say to why there's a difference, because technically this form has been around for both sites for a while now, and I can't speak to that.
Can I interject for 1 second, Raphael?
Yeah.
I know Krista and I used to look at this back in the day of why the MGH wasn't compliant to filling it out and the Glen was. And we know at one point the Glen was writing the dose of narcotic they were giving right onto the opioid sheet. And at the general, we were not. We're putting it on our CMAR. So it kind of made them more compliant at the Glen back in the day. So I know that was the case for many years now. I don't know if they're still doing that, but we did notice that was something we couldn't get the nurses at the MGH to do. But at the Glen, they were doing it. So their opioid surveillance sheet was always filled out, more than ours.
Maybe we should incorporate that process ourselves.
Right now, it's really clear, though, that it has to be found on the CMAR, the time of administration, just to put a note on that. So everybody should be documenting their administration on the CMAR to make sure that we don't overdose. Everyone needs to look at the CMAR first, for sure, though.
Okay.
Nancy?
Hi, thanks. I was just noticing that there was 2 sites that it looks like that there's not much of assessment, but I would assume that there might be an issue because the patient's level of consciousness might not be there. I know in PCU, if a patient's just coming out in phase 1, they won't be able to respond. So we'll document more potential notes concerning the fact of how they're looking behaviorally, and we're unable to assess because the patients are still very drowsy and unable to respond to their pain level. And I think the same thing might go for ICU. So I just wanted to sort of mention those outliers that could be components that are skewing a bit of your results that you're looking at initially, if you're looking at exactly the time that they enter.
I looked at really the first 4 hours of admission. So technically I should capture at least the time they're in PACU. If they're there for that time. But there's definitely and they can actually assess their pain using a behavioral pain scale or another tool like the CPOT for intubated patients. So there's tools out there that whenever we're not able to get that patient self-report. So I was looking for that, for example.
Okay.
Yes,
Okay,
patient
good.
is not able to report, but the clinician should be using a tool
Behavior.
to evaluate
Yeah.
that.
And is it written in notes, or you're reviewing also notes, or just the scale? Your notes.
I was
Okay,
also
cool.
reviewing their notes at admission, the progress notes, so they're in the flow sheets. Yeah, I was reviewing that.
Okay, that's good. Okay, thank you.
Sure. I think I'll take that last one question because it's 2:01. So Cindy, you'll finish off with you.
Okay. Thanks, Nancy. I was just going to bring that up to see when how the audit was done for the PACU. Just one question, Raphael. In the risk factors that you have, I think there were 12 risk factors. Can you just explain to me what number 10 means when the pain suddenly stops? Why would that be a risk factor?
So for example, you have like a reduction of like a broken bone, and then it's being brought back to place. So before, the pain was such intense that you had like your respiratory drive was kind of was déclenché by the pain status. So as soon as that pain is relieved, like suddenly, your patient is now suddenly very calm and relieved. And if you give opiate, and so probably the respiratory drive will now decrease. So because of that, whenever you're giving opiates, that may have an impact afterwards on your respiratory depression. So it's really that respiratory drive that is being driven by that pain, and then suddenly it stops.
Okay, thank you, Rebecca.
All the rationale is also in the opiate policy as well, or you want to go and read it as well. The rationale is there as well. I'm just looking at the chat. Is there anything important? Exactly, yes, the CPOT is a very good tool. Perfect. Everything, by the way, is in the internet, so I really invite you to go. There's a dedicated space for the pain evaluation and management, so everything is on here. So I invite you to go and see and look at it. Thank you very much.
Merci, Raphaël.
Thank you very much.
Thank you.